The new diabetes guidelines are quietly changing what it means to be healthy, especially for people over 60. And this is not just a technical update. In recent years, blood sugar levels that were considered normal for decades have started to be seen as signs of risk, and millions of older adults have been pushed into a category of prediabetes or diabetes without their bodies having changed at all. The question everyone should be asking is, are we truly protecting lives, or are we creating patients who might never have needed intensive treatment? Get ready, because once you understand how these new numbers came about, you may completely change the way you look at blood sugar management. For much of the 20th century, medicine focused on treating truly severe cases when blood glucose rose to levels that already caused clear symptoms. As research advanced, earlier interventions began to be valued, which can be positive, but also opened the door to constantly lowering diagnostic thresholds. Values that used to be seen only as warning signs now define disease, even when the person has no clinical complications at all. The problem is that, just like with blood pressure, each change creates a wave of new diagnoses and, with it, a massive increase in the use of medications and medical services. These changes, however, do not always reflect the reality of people over 60. The aging body has metabolic particularities that are often not taken into account in large studies. What appears as increased risk in population graphs may not represent real danger for an older individual with a stable lifestyle, favorable family history, and no complications. Even so, when new guidelines are released, the numbers carry more weight than the context, and once a diagnosis is given, it is rarely questioned by the patient. This raises an important ethical debate. By making the normal range narrower and narrower, are we truly promoting health or reinforcing a model based on constant surveillance and dependence on therapies? Older people in particular begin to carry labels that generate anxiety, fear of eating certain foods, and a tense relationship with their own body. In many cases, this leads to aggressive interventions that lower blood sugar quickly, but at the cost of dizziness, weakness, and even episodes of hypoglycemia, a much greater risk than the slightly elevated glucose that triggered the intervention in the first place. With this in mind, we need to carefully analyze how these targets are applied and for whom they really make sense. Guidelines are necessary, of course, but they were never meant to replace clinical judgment. Each person has their own metabolic baseline, and what is ideal at 30 is not always safe at 70. At the center of all this lies a question that is almost never discussed. What is the real impact of turning small metabolic changes into new diagnoses? When an entire society starts being treated preventively, who actually benefits? In recent decades, fasting blood sugar targets have gradually been lowered. In the past, values around 110 mmHg DL were considered acceptable for older adults. Today, that same number puts millions into the prediabetes category. This inflates statistics, generates alarming headlines, and creates the impression of an out-of-control epidemic. However, when we look at how these new thresholds originated, we see that many studies were conducted in middle-aged populations with higher cardiovascular risk, not exclusively in healthy seniors. Even so, the results became general rules applied uniformly to everyone. When these guidelines reach the doctor's office, the effect is immediate. People who have always felt well are told they are on the edge, at risk, or that they need to begin intensive monitoring. And here we hit a key point. Blood sugar is not a fixed number. It changes depending on the time of day, sleep quality, hydration, stress, and even the interval between meals. Small fluctuations, especially in older adults, are physiological and should not automatically be used to label someone with a chronic condition. Even so, a single lab result is often enough to completely change the direction of someone's life. What is most concerning is that, after the diagnosis, treatment decisions tend to follow rigid protocols that prioritize numeric targets. This leads many older adults to start medications that, while effective in younger people, can be problematic in more sensitive bodies. Episodes of hypoglycemia are more common in this age group and can result in falls, fractures, and serious complications, increasing exactly the kind of risk that treatment was supposed to prevent. Paradoxically, the attempt to reach an ideal number can reduce quality of life instead of improving it. Making targets more and more aggressive has another silent effect. It reinforces the belief that only drug treatment can control blood sugar. But studies show that simple changes, more balanced meals, short walks after eating, better sleep hygiene, and stress reduction can lower blood sugar in a more stable and lasting way than aggressive medication adjustments. Even so, these approaches often receive less attention because they don't fit the immediate logic of fix the number quickly. When we look at how guidelines have evolved over time, we see a growing gap between what science discovers and how that is turned into broad clinical policies. This gap widens when we consider the influence of economic interests on the process. The more people fall into a risk category, the larger the pool of potential consumers for monitoring programs, new drugs, and recurring appointments. For many health systems, this means more revenue, even if the real health of the population remains stagnant. The core issue is not to ignore the importance of keeping blood sugar levels under control, but to recognize that management must be individualized. Health cannot be treated as a statistical graph applied indiscriminately. This becomes even more important as we age, when the goal is no longer to hit perfect numbers, but to preserve autonomy, strength, mobility, and emotional well-being. And this is where we need to redefine what health truly means for the modern senior. Many professionals are realizing that the way we interpret lab tests needs to change. Instead of looking at blood sugar in isolation, the more up-to-date approach considers trends over time, daily variability, and how it relates to lifestyle. A single high reading after a bad night's sleep should not carry the same weight as a persistent pattern of elevation. Unfortunately, this distinction is still not widely practiced, especially in rushed visits where clinical decisions are based on the most recent lab result. For older adults, this creates a significant practical problem. They end up living in a constant state of alert, fearing every meal, every number that appears on the monitor, every piece of advice from worried family members. Fear often becomes part of the treatment itself, and we know that chronic fear raises cortisol, which in turn raises blood sugar, creating a cycle in which the very anxiety caused by the diagnosis worsens the condition we are trying to control. That is why more and more serious organizations have been recommending that blood sugar targets for seniors be evaluated with much more caution and flexibility. A value slightly above the desired range does not necessarily mean that the patient is in immediate danger. In many cases, the safest response is not to bring blood sugar down quickly, but to understand why it went up and what the person's overall pattern looks like. This kind of approach reduces the risk of hypoglycemia and prioritizes safety over mathematical targets. Even so, the most recent guidelines encourage doctors to act early, even when there is little evidence of long-term benefit for those who are already over 60. Although well-intentioned, these recommendations ignore the fact that metabolism changes with age and that small variations can be physiological, not pathological. By applying middle-age targets to older adults, we create a scenario in which treatment becomes more aggressive than necessary. The consequence is an entire generation being treated as fragile, when in reality, many of these people could live with excellent quality of life through simple interventions and without the permanent label of prediabetes or diabetes. But increasing diagnoses lead to more appointments, more tests, more medications, and inevitably more costs. The lower we set the threshold, the sicker the population appears, even when it isn't. This constant expansion of the definition of disease forces us to reflect on the real purpose of the health system. Are we using science to protect or to standardize, to educate or to label? The way we answer these questions determines the kind of society we will build for future generations of seniors, a society based on autonomy or on excessive medicalization. Many people don't realize that the way we measure blood sugar can completely distort how we assess real risk. Older adults, in particular, are more sensitive to variations caused by poor sleep, dehydration, or late meals, but these nuances rarely come up in a medical appointment. The result is an isolated number that ends up defining the patient's treatment path, even if it doesn't reflect their true pattern. When we reduce a complex organism to a single value, we lose the ability to interpret health in its proper context. The use of continuous glucose monitors, which has become more common recently, should help fix this problem, but often it only amplifies anxiety. Natural fluctuations that would once go unnoticed are now interpreted as warning signs. This leads many seniors to believe they are constantly on the edge of danger, when in fact, the body is just responding normally to daily activities. Too much information, without proper interpretation, can be just as harmful as too little. Another rarely discussed point is that blood sugar is not just a reflection of food intake. It responds directly to the nervous system and a person's emotions. Constant worry about not going over the target creates internal stress that, by itself, alters metabolism. This produces a cruel paradox. The more someone tries to keep blood sugar low, the more the body reacts with compensatory spikes, leading to unnecessary medication adjustments. This is how a dangerous cycle is created, fueled by fear of the number itself. That's why many specialists argue that blood sugar targets should be set in a personalized way, with a focus on the person's history and needs, not on rigid guidelines. A value slightly above target can be less risky than an aggressive treatment aimed at lowering it at any cost. For older adults, safety should always come first. Maintaining stability, avoiding falls, and preserving energy is more important than chasing patterns that belong to the physiology of much younger bodies. In addition, many studies show that small changes in lifestyle can produce results far more significant than successive medication adjustments. Walking after meals, avoiding very late dinners, increasing fiber intake, and ensuring adequate sleep are measures that bring real, lasting effects. Unfortunately, these practices are often overshadowed by the measure and correct mindset, which encourages dependence on numbers rather than deep understanding of one's own body. The truth is, we are living in an era where health is monitored minute by minute, and this can be useful in some contexts, but it can also trap people in a constant sense of vigilance. For seniors, this pressure can be emotionally draining and physically dangerous. The role of the health professional should not be to turn the patient into an inspector of their own body, but to give them back the peace of living with awareness, not with fear. As we age, the body naturally develops compensatory mechanisms that can slightly raise blood sugar without representing an immediate risk. However, when aggressive guidelines are applied indiscriminately, these physiological variations are treated as disease. The older adult is then steered toward treatments that may be much stronger than their body actually needs. This imbalance between therapeutic intensity and real benefit is one of the biggest problems with current guidelines. One of the most serious risks is hypoglycemia, especially in people who live alone or have mobility limitations. Episodes of very low blood sugar can occur silently and suddenly, leading to falls, loss of consciousness, fractures, and hospitalizations. These events are more dangerous than moderately elevated glucose, but in the pursuit of the ideal number, many professionals end up overlooking this risk. The priority stops being the patient's well-being and becomes the achievement of a numeric goal. Furthermore, the intensity of drug treatment often fails to account for the real routines of older adults. Many have irregular meal times, varying activity levels, and difficulty following complex dosing schedules. This mismatch between theory and real life creates a situation where treatment itself becomes a source of stress. The senior starts to fear taking the wrong dose, missing a pill, or eating the wrong thing, as if their health depended on a balance that is impossible to maintain perfectly. Another crucial aspect is drug interaction. Many older adults are already taking medications for blood pressure, sleep, chronic pain, or heart issues. Introducing diabetes drugs aggressively without fully considering these interactions increases the risk of side effects, some of them serious. Yet this still happens frequently because guidelines favor standardization instead of personalization. The result is a treatment that may be technically correct, but completely disconnected from the patient's reality. This therapeutic excess also has emotional consequences. The older adult begins to believe their body is failing, when in truth many of their metabolic variations are natural for their stage of life. By labeling small changes as disease, we create a sense of fragility that does not match their actual health status. Self-confidence decreases, autonomy shrinks, and the person starts living under the constant shadow of a diagnosis that may not even represent a significant risk. Finally, we need to acknowledge that aggressive targets prolong treatments that generate unnecessary costs for both patients and the health system. Frequent appointments, repeated tests, multiple medication adjustments, and avoidable hospitalizations are common outcomes of overly rigid guidelines. This not only overloads the system, but drains resources that could be directed to those who truly need them. The more people are labeled as sick, the less attention is left for severe and urgent cases. This is where we need to completely rethink how we care for the health of older adults. Instead of imposing inflexible targets, we can build a model that prioritizes safety, autonomy, and quality of life. That means interpreting numbers wisely, understanding that small variations are normal, and adopting strategies that strengthen the body instead of weakening it with excessive interventions. Medicine should be a tool of protection, not of anxiety. The first step is to give seniors back control over their own health. This does not mean abandoning medical follow-up, but integrating tools that help them understand trends over time, not just isolated values. Repeated measurements at different times and in real-life conditions offer a much more accurate view of what is happening. This kind of conscious monitoring gives patients a sense of safety without trapping them in constant surveillance. We also need to value prevention that truly works. Regular walks, a diet rich in fiber and protein, proper hydration, stress management, and good quality sleep are pillars that lower blood sugar in a stable, natural way. These practices do not cause hypoglycemia, do not require complex dosing, and improve overall health. In older adults, such interventions can be more effective and safer than any aggressive medication adjustment. At the same time, health professionals must adopt a more human and individualized approach. That means asking more questions, listening more, and considering the patient's life context before setting targets. Slightly higher blood sugar can be acceptable if the person is functional, active, happy, and symptom-free. Less rigid targets are not neglect. They are clinical wisdom and respect for the physiology of aging. When we apply this broader vision, we realize that health is not in a numeric range, but in the ability to live well. The goal is not to turn seniors into experts in blood sugar, but to allow them to live with energy, freedom, and peace of mind. Reducing the weight of diagnoses and giving patients back their protagonism creates a system where care becomes lighter, more efficient, and above all, safer. Finally, it is essential to reflect on the impact of modern guidelines on society as a whole. When we expand the definition of disease, we also expand dependence on treatments. But when we strengthen education, prevention, and autonomy, we create a population that is more aware and healthier. The choice between these two paths determines whether the health system will be an instrument of care or a mechanism of excessive medicalization. As professionals, our responsibility is to promote balance, not fear. If this analysis has brought you more clarity about the new guidelines and helped you see your own health with greater awareness, remember to like this video, subscribe to the channel, and share your experience in the comments. Your participation strengthens this community and helps other people make safer, more informed choices. Thank you for being here, and keep taking care of yourself with wisdom and autonomy.